So, hello everyone, welcome to this second NAFLD NASH session. So, the title of this session is The Real Life Through Clinical Cases. And I will co-chair this session with Jerome Boursier.
Hello everybody.
Yeah. So, what is very important, because it is a very interactive session, you can send your question by the chatting. It's very important we have your question, and we'll ask to the speakers. So maybe, Jerome, we can start the session now. I think I have not forgotten everything.
Yes, thank you, Laurence. Welcome to everybody. I'm really happy to be here for this session. And let's start immediately with the first clinical case about lifestyle modification presented by Ana Carolina Cardozo. So Ana Carolina, let's go. The floor is yours.
Thank you, Jerome. First of all, I'd like to thank Professor Patrick Marcelin, the kind invitation. It's always a pleasure to participate. My disclosure. Well, this case is about Jane. She is a female and 48 years old. She came to our service with some complaints as fatigue, frequent headaches, and difficult to sleep. She associated these complaints to liver steatosis that was detected in her abdominal ultrasound. She has been struggling with her weight for many years now and has tried several diets without success. She is a recreational drinker with a sedentary behavior, work all day long, don't do any physical activity, and has a diet high in processed foods and sugar, and with poor intake of vegetables and whole grains. All her 3 children are obese, but she has no family history of NAFLD or NAFLD cirrhosis in a first-degree relatives. 3 years ago, she was diagnosed with pre-type 2 diabetes, 5 years ago with hypertension, and 10 years ago with dyslipidemia. She has obesity, and she's treating nowadays with metformin, 500 milligrams twice daily, with hemipil 10 milligrams daily, and atorvastatin 20 milligrams daily. Her physical examination showed a blood pressure of 142/88 with a normal heart rate and a normal exam of the cardiovascular system. She has a body mass index of 31, and the exam of her abdomen showed a soft but with a hepatomegaly abdomen, 3 centimeters from the right lobe. We performed some additional laboratorial tests. The fasting glucose was 148. The glycated hemoglobin is 6.4%. She has a high triglyceride and high LDL. She has also high liver enzymes. The ALT was 51 to a normal upper limit of 35, the AST 44, and the GGT was 75. The platelet count was completely normal. And we also performed some additional tests. We redid her abdominal ultrasound, and we also find the hepatomegaly, as we saw in the physical exam. She has also a severe steatosis, a normal spleen, no signs of portal hypertension. We calculated FIB-4, 1.24, so it take her from the liver advanced fibrosis. And we also performed FibroScan. The result was 6.6 kilopascals with a cap of 385. So the question is, what would be the best approach, the main approach for this patient? If we should modify the hypoglycemic therapy, use more metformin on other medications, we should use another treatment for a new treatment for anti-obesity. I mean, we have now some approved drugs, we have off-label drugs that we are using for obesity, if it should be the best option for this patient. If we should propose the lifestyle modifications, or just send the patient to the surgery and propose her bariatric surgery. So you should vote now.
So let's vote.
Hello.
People are voting. So the situation is quite stable. Can we appear the results on the screen? I can tell it with my voice. So 2/3 of the patients are voted for lifestyle modification. This is clinical case. 1/4 of the patient, I said, modified hypoglycemic therapy, and very few people were in favor of anti-obesity treatment and bariatric surgery. So lifestyle modification mainly, and little modified hypoglycemic therapy in this patient with obese, with liver parameter that are quite reassuring. So what is your answer, your opinion, Anna Cardozo?
So, of course, we also think that the first thing for this patient is to do lifestyle modification. We propose some changes in the dietary, increase physical activity, start physical activity, and do some techniques for stress reduction. We have nowadays a lot of data talking about dietary modification. So we propose a diet high in fiber, low in saturated and trans fats, enriching fruits, vegetables, whole grains, lean protein, and healthy fats. We try to tailor for her with our nutrition team eating plan with respecting her preferences and cultural backgrounds. Of course, she cannot eat everything that she loves, but trying to adapt to her lifestyle and to her real life. We also propose her to start a physical activity. We encourage her to engage in regular physical activity, walking, cycling, swimming for at least 150 minutes per week. And we also encourage her to start some of the techniques as meditation or yoga or deep breathing to explore stress reduction. That's not easy, but it's really important because she has a very busy life, a mother's life, and it's a woman that works a lot. So we try to find some point for her to make her more calm and more conscious, to try to help in this process. But unfortunately, when she came back for us 6 months after, she had a poor adhesion in the dietary modification. She tried by herself, even if we gave to her some options in the daily life, but she has a poor adhesion. She tried by herself an intermittent fasting for 2 months. She lost some weight, but she regained after almost all the weight that she lost. The good thing, I think, is that she started a physical activity. She's nowadays walking twice a week, 30 minutes, and I think it's better than nothing. So, of course, it's not the ideal, but it's what we got. And she's not engaged at all in the stress reduction. We talked a lot with her about it and tried to be more conscious about the life and try to have this time for her, but it's really difficult. We did again all the blood tests and the blood glucose and the glycate, the hemoglobin was a little bit lower, but not the ideal. The triglycerides and the LDL are still higher, and the liver enzymes are still higher than the limit. So we did not achieve as we wanted a better results. It's something, but it was not the ideal. So these patients, it's the clinical case from the real life, and it's to show how difficult it is to manage these patients that are coming for us nowadays, young patients, but with a very difficult adherence to the treatment.
Many thanks, Anna Carolina. So I think this clinical case very nicely illustrates the situation we see most frequently in clinical practice. So an NAFLD patient with quite reassuring liver exploration, so suggesting simple steatosis or NASH, for whom the key point and also the challenge, as you said, is the management of lifestyle, improved nutrition, improved physical activity. And this clinical case nicely introduced the next talk from Manuel Romero Gomez, who will speak us about the role of lifestyle modification in NAFLD. So Manuel, it's your turn. So can we have the video, please?
Good afternoon, everybody. It's a great pleasure for me to be here, and I would like to thank Professor Patrick Marcelin and Marc Boursier for inviting me one more year to participate in this fantastic digital congress. Today, we are talking about the role of lifestyle in the management of patients with NAFLD. This is my conflict of interest, and I would like to start showing you the key point, the key impact of the diet on this disease. The diet could be the solution, but could be also the cause, the etiology of the NAFLD. This is the case of a girl attending in our office, and she underwent this liver biopsy showing just steatosis, but after that, suffering from multiple sclerosis, start a therapy with dimethyl fumarate and receiving a high-fat diet. In this high-fat diet, increased body weight more than 20 kilos, and the liver biopsy impairs dramatically to F3 stage. That means the diet is very important. And in this fantastic review by the Tony Vidal-Puig group, from an adipocentric point of view, they demonstrate how fat could be the driver of the progression of NAFLD, together with the microbiome, because we have these two big axes. We can address both, taking account all time the genetics. Here you can see how PNPLA3, TMX6S2, the MBOAT, and HSD17B13 could play a major role modifying the impact of the diet and the exercise, trying to modify the adipocentric hypothesis and the microbiome axis hypothesis. This is our classic study in which we demonstrate that doing an intervention with a hypocaloric diet and physical activity, we can promote weight loss, and if we reach 10% weight loss, we can promote NASH resolution in 90% of the patient, fibrosis regression in 80%, and steatosis improvement in 100%. But the main problem, or the bad news in this study, was that 10% of the patients reached this 10% body weight loss. That we need to analyze what is the main reason for that. Perhaps it could be the diet, and we try to compare a standard hypocaloric, low-fat diet versus an hypocaloric Mediterranean diet in this randomized control trial, and demonstrating that both diet will be very useful to promote improvement of steatosis hepatitis, and we can find many small differences between both diets. At the end of the day, Mediterranean diet seems to be a little better improving steatohepatitis, increasing the steatohepatitis resolution rate, and decrease AST, GGT, total cholesterol, and APRI score that did not happen in the low-fat diet. That means perhaps we can select a Mediterranean diet instead of a hypocaloric low-fat diet. But when we are taking account the diet, we analyze all time, all the micronutrients, all the food, all the meals together, because separately they don't have any specific impact. Taking account the habit around the world, you can see how the different diet that you can classify in this very nice study. You can see how if the diet is belong to this geometric figure, you can be quite confident. But we need also to take an account how far we are from the ideal diet for this patient. And this is the geometry of the nutrition that you need to keep in mind. We need to do a Mediterranean diet, or closer as much as possible to the habit of the patient and to the ideal diet. The shorter space, the better result. But together with the diet, we need to implement a change in the lifestyle. We don't need to have runners, marathon runners. We need to invite people to avoid sedentary and to work together, taking account different aspects when we are prescribing exercise. The frequency, the intensity, the type of exercise, is aerobic or resistant, the time, and the volume. Taking account of these parameters, we can design the best option for our patient. From a very simplistic manner, we can use the Boursier zone algorithm and divide patient in three big groups. the sedentary behavior, the light activity, and the active fitness. And if we take our iPhone, we can take into account the number of steps we are walking every day. If lower than 5,000, we are in a very bad condition. We need to increase over 5,000. But if we are walking more than 10,000, 12,000 steps, we are in a very active manner to fight against this disease. How can we address that? This meta-analysis from 2017 demonstrates how both aerobic and resistant exercise will be useful fighting against NAFLD. Doing exercise, we can remove fat from the liver. And many meta-analyses demonstrate that a combined exercise, aerobic plus resistant, or high intensity plus resistant exercise, we can remove safely fat from the liver. Even in this meta-analysis, including a large number of studies, all of them demonstrate that the key point is to avoid sedentary behavior. If we are doing any physical activity, any exercise, we can decrease the intrahepatic triglyceride concentration. And this study by a team from Pennsylvania demonstrate that the exercise, independently of weight loss, could promote fat improvement of fat and reduction in the liver. In this meta-analysis, they demonstrate that the mean change in the fat concentration was minus 24% in comparison with an increase of 7.3% when compared with the standard condition. That means exercise per se is able to promote fat reduction in spite of not promoting weight loss. Here you can see how the percentage of patients losing more than 30% in the hepatic fat concentration that has been a surrogate biomarker of future response to the therapy that could happen in the 40% of the patients with more than 750 MET in comparison with people lower than doing a physical activity lower than 750. That means we need to move, we need to go ahead to incorporate the intervention, the lifestyle intervention in the management of this NAFLD, of the patient with NAFLD. And from my point of view, the key point is to put at the beginning. When a patient goes to our outpatient office and we are attending, we need to stratify perfectly if the patient is suffering from obesity, diabetes, or they are suffering any other group to be correctly stratified. And after that, we need to analyze how the fitness of the patient is, taking account the steps they are doing every day and how the diet is, and how can we move this patient to a more healthy diet, basically Mediterranean diet, trying to be closer as much as possible to the standard habit in this geographical point, in this geographical country, and taking account the genes, the sex, the age, and the comorbidities. We need to implement this lifestyle intervention, exercise and Mediterranean diet. After 12 weeks, we can classify patients as responders or not. If the patient is responders, it's a fantastic news, and we can go ahead keeping for long term the lifestyle intervention. But if patient is non-responder due to low adherence, due to a specific genes, a specific group stratification that did not allow the patient to be responder to a lifestyle intervention, in this case, this intervention is a leading phase. We can be absolutely confident our patient require more active intervention beyond lifestyle, for example, participating in clinical trials or doing any other, or receiving any drug therapy. This is, from my point of view, the space in which we need to implement lifestyle intervention in our patient. And thanks for all my teams in Brujan del Rocio and the Institute for Biomedicine of Seville, because they are working very hard on that. Thank you. Thank you for your attention, and I'm more than happy answering your question.
Many thanks, Manuel. That was a very nice talk. Don't hesitate. I am speaking for the audience. Don't hesitate to ask your questions online, so that we can ask them to the speaker. So I have a first question, Manuel. You have spoken a little about genetic, and in your study you plan to study the effect of genetic on response to diet. There was a nice study last year published in Gastroenterology about people who experiences a diet intervention, and they show that weight loss was modulated by genetics and also by gut microbiota. So do you think that there are good candidates due to genetics and gut microbiota and bad candidates for lifestyle intervention? Because you know that very few people finally respond. It's very difficult to achieve and to maintain the goal. So what's your opinion about that?
Thank you, Jerome. It's a very nice question. It's a fascinating question because as we can read in this paper, depending on the genetic background, you have more or less possibility to respond to a lifestyle intervention. And this aspect is very, very important because currently, if you are bearing the geno GG in the PNPLA3, as you know, is related to more advanced steatosis, hepatitis, fibrosis, even liver cancer. But if you are implementing a lifestyle intervention, your possibility to be responder is much higher in comparison with non-GG. That means this is the active second part of the stratification. We can have the genes, we can implement lifestyle, but we need to be absolutely confident that doing that in patients with a negative genetic background have more chance to respond to the lifestyle intervention. But at the end of the day, I think we can implement both the genetic study and the lifestyle intervention to allocate perfectly the patient in the correct stratum.
I have one question for you, Manuel. So lifestyle change is the first-line therapy in NAFLD patients. What's about the patients with normal body mass index? Do you, for those patients, do you promote weight loss, exercise? What is your
in patients with normal body weight, we need to exclude obesity, visceral obesity. As you know, some people with normal BMI, they are showing visceral obesity, like in Mexican and people, in Hispanic people in the state. And after the fair analysis, my patients need to be excluded to be suffering from visceral obesity. In case that they are showing visceral obesity, I implement in the same manner, lifestyle, including diet and exercise. But if my patient is a true lean NASH, I'm reinforce the idea of the exercise. This is the data of the Jonathan Steen demonstrating how the exercise could promote improvement of the liver in spite of not promoting weight loss. And I think for me, it's a maximal that we need to implement in clinical practice. Lean NASH need to do exercise to be as much fitness as possible. And I think it could have a beneficial effect on the liver.
You have question? Yes, question, Jerome, by the chatting. I don't have any question at this time.
No, there's no question for the moment. So Manuel, you presented different diets. The EASL in its latest guidelines for 2016 is quite long, but they will be soon updated. But for the moment, they are the latest. They recommend the Mediterranean diet. So do you think there is any better diet than the other? What would be your advice? What are your thinking? Is there different things that give the same results when you weight loss? Or is there an importance about the quality of the diet?
Yes, this is the main reason by which we designed the clinical trial comparing Mediterranean diet versus low-fat diet. The idea was to demonstrate that olive oil, a supplementation of olive oil that means more fat, that means more calories, could be beneficial. And this was a very we did not demonstrate any statistically significant difference in the main endpoint, but just in minor and surrogate endpoint, we demonstrate that a Mediterranean diet could be superior to low-fat diet. But the main idea is you can eat fat and you can eat calories, and you are improving your liver. Then at the end of the day, we are recommending that people, they are doing the diet closer to the habit, the diet they are doing, and trying to avoid the food that they are not allowed in the Mediterranean diet, but reinforce all the fruit, vegetable, olive oil, etc., in the Mediterranean. No? At the end of the day, I feel Mediterranean diet is much better. It's not just because we are close to the Mediterranean Sea that I have here in front in Barcelona. Is because the diet requires adherence, and if the people is happier doing this type of diet, I think we will be more successful managing this disease. No, and we don't need a marathon runner. We need people that move, that they avoid sedentary behavior. No, this is the key point. In the diet, it's the same. Just to look at what are you eating. You don't need to be a completely different and the opposite diet that you are eating every day. You need to move specifically a couple of 3, 4 aspects that we can translate and that we can avoid, and we can be doing a Mediterranean diet. Just a comment that we are highly fascinated with the ChatGPT, the artificial intelligence to recommend activities. I think this artificial intelligence could be very, very helpful, trying to find the better diet for each patient, taking account the habits and also the customary of the patient. I think we can have one diet per patient, and they could enjoy, I hope, cooking with the best foods.
Okay, thank you, Manuel. I think, Jerome, we can move to the next clinical case. So thank you, Anna. So now the next clinical case will be presented by Cyrielle Kossi. So Cyrielle.
Thank you, Laurence. Thank you, Jerome. And thank you for Professor Marcelin and Professor BOURSIER for the kind invitation. In this next clinical case, we would like to highlight how we can manage the comorbidities of patients with NAFLD. So here are my disclosures. And I will present you a clinical case of a patient that has been referred to me. We know that you probably know that we have implemented a pathway for the screening of patients, but we also have a pathway where the patient that are seen in hepatology can come back to the endocrinology and nutrition department, so that we can also help to deal and take care of all the metabolic comorbidities that this patient may have. And this is the one woman that is 60 years old woman with type 2 diabetes. She has obesity grade 1. The BMI is 31.6 kilogram per meter square, and she has been referred from the hepatology department because she has NASH with advanced fibrosis. I'm showing you just the basic imaging that she had, an abdominal ultrasound that shows hepatic steatosis without any lesion, dysmorphia, or portal hypertension. And due to an elevated liver stiffness, you see that the FibroScan result is pretty high, 12.3. She had a liver biopsy that classified the patient with NASH and the stage of fibrosis F3. She also has dyslipidemia, hypertension, and multi-heteronodular goiter. And this is the context where the patient has been referred. If we look at all the presentation and some of her labs and clinical characteristics, you see that the blood pressure that has been measured really in an optimal condition is 146 upon 96 millimeter per mercury. She has elevated liver enzyme. I will not focus too much on this because she has been referred by the hepatologist, and we also have now a diagnosis, and it's due to NASH fibrosis F3. She had a lipid panel showing a triglyceride of 2.44 millimole per liter. The HDL cholesterol is 0.88 millimole per liter, and the LDL cholesterol is 4.1 millimole per liter. The kidney function is normal, and the HbA1c is 7.2%. If we look at her treatment, she is treated for diabetes with metformin, 1,000 milligram twice daily, and also sulfonylurea, glycoside, 120 milligram once daily. And she has a combination of therapies for the treatment of hypertension using piridopril and indapamide, 5 milligram and 25 milligram once daily. She doesn't smoke, and she does drink a little bit of alcohol. She has a moderate consumption with 1 drink per day. So we would like to stop here and ask the audience what they would do, or how could we potentially take care or improve the comorbidities of these patients. So I think it's time now for the voting in the audience. I don't know if you can see the polls. And the question is, how will you manage the comorbidities of the patient? So would you modify the anti-diabetic therapy? Would you propose a bariatric surgery? Do you think we should add a statin therapy? Do you think we should modify the antihypertensive therapy? And does this patient needs to be screened for obstructive sleep apnea? So I think please let's everyone answer the question. I don't know if you want to comment, Jerome or Laurence. I think there's a few minutes left for the vote.
Okay, I don't have the result. Do you have the result of your screen, Jerome?
Yes, I have.
Comment because I don't have it.
Okay, I will tell you the answer. 40% agree to modify the anti-diabetic therapy, and 40% also add a statin therapy. This is the two most chosen proposition. And after you have equality, 20% B, D, and E, bariatric surgery, antihypertensive therapy, and screen for obstructive sleep apnea. So the most chosen are E and C.
Yeah.
All right, screen for obstructive sleep apnea and the anti-diabetic treatment, right? Okay. So we can move on, and I will just go over all this strategy that we can implement. There's many things we need to do and we can do for this patient. So first, diabetes. When we look at the treatment, there's definitely room for optimization. We just heard in a previous session with CanQC that there are some anti-diabetic therapies that have shown some potential benefit in terms of the liver, and we also know that this patient is probably at a higher cardiovascular risk. So definitively, I would prefer an anti-diabetic therapy with hepatometabolic benefit. And in that case, I think it's safe to keep the metformin, but the two other drugs that we can offer would be in priority pioglitazone or GLP-1 receptor agonist, because they have shown a benefit in terms of improving NASH. And I would remove the glycoside because the HbA1c is almost at the target and we expect a benefit with this treatment, whereas there is no benefit and a risk of hypoglycemia with the sulfonylurea. So definitely, I think it's important to make sure that we optimize the anti-diabetic treatment. The other thing is, how will I take care of the BMI and the obesity? We saw that the patient has obesity grade 1. We've talked a lot with the previous speaker about the need to take care of the lifestyle intervention. Shall I move a little bit? I think I have a problem with my screen. It's going too fast. I'm sorry. I will go back. Well, I lost control of the my slides. Sorry about that. So let's go back. Okay. No, feel going too fast. It's very sensitive. I'm really sorry about that. So lifestyle modification, I will not talk too much about this. We talked about that earlier. For sure, also, she has severe fibrosis, so we will advise to avoid any alcohol consumption. I'm sure we're going to talk about this afterwards. And there's many things we can do beyond lifestyle modification and the Mediterranean diet and physical activity. There is new anti-obesity treatment that at least we need to discuss. There's 2 therapies that has been approved so far. Semaglutide 2.4 weekly and liraglutide 3 mg daily. So depending on the availability and possibility of access, we should be able to at least offer that. And the other option would be to discuss metabolic bariatric surgery. And in that case, I think it's really a personalized decision. You need to explain to the patient the different option and try to discuss with her what's the best option and what would she prefer in terms of treatment for obesity. Then we will move forward and go a little bit more into the hypertension. Obviously, the blood pressure is not too elevated, but it's above the optimal target. A patient with type 2 diabetes should be below 130 and 80 milligram of mercury. So I think it's really easy, and anyone could do that, even if she's seen in a hepatology clinic. Please improve the dosage of the antihypertensive therapy to make sure that she's in target, because what we observe is a lot of therapeutic inertia. And so make sure that at least if she's taking a treatment, she should be in the target for the blood pressure and the optimal blood pressure. So definitely we're going to optimize the antihypertensive treatment. And then if we go to the lipid panel, we can see here that she has dyslipidemia. She's obviously at higher cardiovascular risk. She has multiple risk factors. She has a hypertension, type 2 diabetes. So the LDL cholesterol should be below 1.3 gram per liter based on the European and American recommendations. So this patient definitely could benefit from a statin in terms of prevention for cardiovascular disease. And lastly, of course, there's a strong association with between NASH and obstructive sleep apnea. So definitely make sure that the patient is screened. It's a very easy way to do. You use a score, which is called the Epworth score. It's a questionnaire that you can ask to the patient, and the score was quite high. The score was 8 in this patient. She was referred for sleep screening, and she was confirmed with an indication of treatment. And this also is potentially likely to improve all the metabolic comorbidities of these patients. So I think it's a pretty nice overview of what we can do. And just as a summarize, this is basically everything that I use when I'm seeing a patient with NASH. I would like to check for the comorbidity, consider the treatment, especially if she has type 2 diabetes. We can optimize the treatment. This patient did not have cirrhosis, but of course there's a huge benefit in the patient if we need to make sure that we screen for HCC. Weight loss intervention, lifestyle, obesity treatment, bariatric surgery. There's so many things we can do right now, even though there's no approved treatment. And don't forget to manage the comorbidity, hypertension, dyslipidemia, and sleep apnea, which increase the cardiovascular risk. And with that, I would like to thank you for your attention. Laurence, I think you're on mute. Yeah.
So thank you, Sayal, for your very nice presentation. So I think for the discussion, we have the discussion after at the end of the session, after the presentation, there is 2 more speakers. What do you think, Jerome? We have time for the question, or we wait for?
No, we are on time. So let's do the 2 talks, and then we will have a global discussion at the end.
Bon. Okay, so the next presentation is about the management of comorbidities, and the speaker is Elisabetta Bugianesi. So Elisabetta.
Thank you, Mr. Chairman. Dear colleagues, let me first thank Patrick Marcelin for this kind invitation. These are my disclosures. As you know, NAFLD is not just a liver disease, but it is part of a multi-system disorder characterized by metabolic stress and systemic inflammation that also hits arteries, heart, liver, pancreas, and kidneys. The clinical outcomes are several in NAFLD. Here you can see the report from the NASH CRM cohort, where almost 2,000 adults with NAFLD were prospectively followed for a median follow-up of 4 years. So it is clear that increasing fibrosis stage is associated with an increased risk of liver-related complication and death, and that death from liver disease predominates in patients with advanced fibrosis. But if you look at patients without advanced fibrosis, then the most common causes of mortality are cardiovascular disease and non-hepatic malignancies. And here in this table, you can see the underlying cause of death stratified by fibrosis stage at enrollment. So while liver-related deaths are the most common in cirrhosis, if you look at stage F02, then you see that malignancy is the most common cause of death. During this longitudinal follow-up, the most common onset non-hepatic outcomes were hypertension in descending order, hypertension, type 2 diabetes, chronic kidney disease, cardiac events, non-hepatic cancer, and cerebrovascular events. And of note, the incidence of cardiac events and non-hepatic cancer were similar across all fibrosis stages, so we shouldn't forget about these two complications, even in patients with cirrhosis. Now, the bidirectional relationship between NAFLD and type 2 diabetes is very well known. So type 2 diabetes is a risk factor for NAFLD, but on the contrary, NAFLD carries a twofold increased risk of incident type 2 diabetes. And if a diabetic patient has NAFLD, this is associated with an increased prevalence of chronic kidney disease and retinopathy. Now, this meta-analysis shows you the full spectrum of cardiovascular dysfunction related to NAFLD, starting from subclinical atherosclerosis, whose risk is increased by twofold, then fatal and non-fatal cardiovascular events, again, a twofold increased risk in patients with NAFLD, atrial fibrillation, and this is particularly true for patients with type 2 diabetes and NAFLD, and last but not least, cardiac dysfunction, that is left ventricular diastolic dysfunction that can lead to heart failure with preserved ejection fraction, and the risk is increased by twofold again. There are several studies that confirm the risk of extrahepatic cancer in NAFLD. This is a study on the German population, a sample representative for 7.3 million people, followed up for 10 years. And as you can see on the left, the incidence of malignant tumor is increased 15% in people with NAFLD compared to people without NAFLD. The most common cancer are those of female genital organs, followed by digestive organs, in particular colorectal cancer, but also prostate, breast, and urinary tract. And these data have been recently confirmed in another meta-analysis. As you can see, the risk of extrahepatic cancer is always increased despite a large variability in the study. And overall, extrahepatic cancer are over 8-fold more frequent than HCC in NAFLD, and are not associated with liver fibrosis stage. Again, the highest incidence rates were for uterine cancer, breast, prostate, colorectal cancer, and lung cancer. What do the clinical practice guidelines suggest? We know that the European guidelines recommend screening of the cardiovascular system as mandatory in all persons, at least by detailed risk factor assessment. And also screening for diabetes is mandatory by fasting or glycated hemoglobin or glucose tolerance test. And the recently released clinical practice guideline from the American Association for the Study of Liver Disease still confirm that optimized management of cardiovascular risk factor is critical to improve outcome in patients with NAFLD. They should be also screened for the presence of type 2 diabetes. The guidelines also remind that the prevalence and incidence of chronic kidney disease is higher among these patients, particularly patients with NASH and advanced fibrosis. And again, the death from non-hepatic malignancies is a common cause of death. So in managing the patient, we should not forget adherence to age-appropriate cancer screening. They also mention obstructive sleep apnea, so patients with NAFLD who are overweight or obese should be screened for OSA. What about management? Of course, the management of the risk of cardiovascular disease is very important. And once again, statins are safe and recommended for cardiovascular risk reduction in patients with NAFLD across the full spectrum of the disease, including compensated cirrhosis. We can give statins, but also ezetimibe, PCSK9 inhibitors, fibrates, and so on. However, there are limited data on the safety and efficacy of statins in patients with decompensated cirrhosis, so they can be considered in patients with high cardiovascular risk, but with a careful monitoring. Hypertriglyceridemia can be managed first through lifestyle change and eventually with supplementation with omega-3 fatty acid, icosapentaethyl, or fibrates. It is important the optimized use of available medication, for example, the one already approved for type 2 diabetes. Although there are currently no FDA-approved medication for the treatment of NAFLD, some drugs approved to treat associated comorbidities may be considered in the appropriate clinical setting. So semaglutide can be considered for its approved indication in type 2 diabetes and obesity, as it confers both cardiovascular benefit and improves NASH. Pioglitazone improves NASH and can be as well considered in patients with NASH and type 2 diabetes, while we should not use metformin and DPP-4 in diabetic patients with NASH because they do not offer a meaningful histological benefit. And I'd like to conclude reminding us that the patient with NAFLD is a very complex patient. I told you about the main extrahepatic comorbidities, but you should also don't forget about gallstone disease, polycystic ovary syndrome, and even cerebrovascular disease. So it is clear that we need a multidisciplinary management in this patient, and we are looking forward to it. And I thank you so much for your attention.
So, good afternoon, dear colleagues. It is a great pleasure to be in this meeting. And my task today is to talk about the role of alcohol in the context of NASH, NAFLD, and real life through clinical cases. I also thank the organizing committee and particularly Patrick Marcelin. So my disclosures are the ones showing here. Okay. And I think that regarding the role of alcohol in NAFLD NASH, there are several main questions. One is, what is the amount of alcohol consumption that in fact may contribute to disease progression? The second is, what are the effects of mild alcohol consumption in the prevention or in the risk progression of NAFLD? And finally, and of course more important, is what advice should we give to our NAFLD patients regarding what is the safe amount of alcohol they can drink. It's also of note the importance of a new nomenclature in order to evaluate alcohol contribution. In fact, the new proposed nomenclature of MAFLD or steatotic liver disease, we don't know yet exactly, is going to facilitate a better understanding of the contribution of different amounts of alcohol to the risk of disease progression, and also allow the emergence of newly recognized disease subtypes to address the impact of disease heterogeneity, including the role of alcohol on disease progression and on response to therapy. And this is according to the new released AASLD guidelines on NAFLD NASH. The fact there is still controversial regarding this new nomenclature. So what is the risk of progression associated with alcohol? It depends mostly on the presence and on the severity of comorbid situations, genetic factors, and environmental factors. And we have already heard about this. Alcohol use can be an important contributor to fatty liver disease progression and should be quantified in all patients, although this is often particularly difficult. It starts with a problem of the definitions of alcohol consumption that are not the same worldwide. I've used these definitions from the AASLD guidance, where we consider mild up to 20 grams in women and 30 grams in men per day, moderate between 21 and 39 in women, and 31 to 59 in men, and finally heavy if it is more than 40 grams for women and more than 60 for men per day. The problem is that a reliable history of alcohol consumption is difficult to obtain, and it's also cumbersome, mostly considering the lifetime span, with periods of abstinence and others of relapse, as well as underreporting and recall bias from the patients. So we need more objective and reliable methods, such as, for example, the phosphatidylethanol that can be measured in the blood or in the hair. And in fact, a recent study from Sweden, from Blomdahl, has done a study where at baseline, all patients had an alcohol consumption of less than 140 grams per week, a group of NAFLD patients. And those were submitted to ALDIC questionnaire and the analysis of PTD in the whole blood done regularly. And what happens, as you can see here, is that if you use the alcohol consumption from ALDIC or from an interview, there is no difference between those who progress from those who don't progress and those who have a significant progression. However, when you use the PT value or the percentage of those with binge drinking, then the significant progression is associated with higher values of PET or with higher frequency of binge drinking, with the significance. Furthermore, the authors found that PET strongly correlates with low to moderate alcohol consumption in NAFLD patients and thus can be used to monitor alcohol consumption in these patients. Finally, the other conclusions from this particular study is that significant fibrosis progression associates with high alcohol consumption and significantly higher PET. That consumption of more than 66 to 96 grams per week, but always less than 140, that is moderate alcohol consumption, was associated with increased risk of significant fibrosis progression when compared with no or low consumption. And finally, that NAFLD patients consuming moderate amounts of alcohol are at increased risk for significant progression and development of cirrhosis-related complications. This is also in agreement with this old study from Ash and collaborators, where they have shown that even social consumption of alcohol may increase the risk of HCC when compared with those that never drink. But other studies have shown the opposite. In fact, this study published, that is a systematic review published in 2001, demonstrates that the effect of modest alcohol consumption on NAFLD is that advanced fibrosis in high-quality studies has a odds ratio for less possibility of developing fibrosis than for those non-drinkers. The explanations the author found for this fact is that the modulation of insulin sensitivity and anti-inflammatory effects of modest alcohol intake may result in the attenuation of intrahepatic lipid synthesis and subsequent hepatic steatosis. On the opposite, but in the same study, this study includes 14 cross-sectional or cohort studies, including a total of more than 14,000 patients. And I could see that the development of HCC was higher in the modest drinkers than in those who do not drink. Also, another study now on the opposite direction, that is the study from Aberg and collaborators, that includes 8,300 persons with hepatic steatosis that participated in the health examination surveys. And what they have shown is that there is a very close dependent correlation between the amount of alcohol consumed and the probability of advanced fibrosis. And this is either in men or in women. This is the same from the same article shown here, where, as you can see, even low alcohol intake in fatty liver disease, mostly if it is not based on wine, is associated with this increased risk for advanced liver disease and for cancer. So, in summary, we may say that among the different studies, there is a large heterogeneity. The difficulties come more for difficulties in comparing studies, since some do comparisons with total abstainers, while others compare with light drinking. And so I think that the major problem is on the effect of this light drinking, and sometimes the definition is not exactly the same, as I previously mentioned. However, in total, a significant evidence that even low alcoholic intake increases the risk for advanced liver disease or cancer. Liver cancer, I'm not discussing the risk it has also for other cancers besides the liver cancer, but it is well known that it does. So, and in what we should have in mind and what we should say to patients is that alcohol can be a cofactor for liver disease progression, and that intake should be assessed on a regular basis. And patients with clinically significant hepatic fibrosis, more than F2, should abstain from alcohol use completely. Again, this is according to the AASLD guidance, the recent one. And thank you very much for your attention.
Thank you, Elena. So we have two very important presentations regarding the comorbidities and the role of alcohol. We can also discuss, of course, the clinical case of Cyril. Cyril, I think you had some question about your clinical case, because I don't have the question. You have question, Jerome?
Yes, we have. There is a question from Cyril. What is the best option for a patient who is taking metformin if you want to update the treatment for diabetes? So pioglitazone or semaglutide, as you proposed? Which one?
Excellent question. As you notice, I didn't choose in my clinical case. I let it open. Well, I think it's really depending on the setting, the patient preference. If you want to compare both treatment, pioglitazone is an oral drug. The other one is an injection once weekly. So it may be a barrier for some patients, but usually when you explain the benefit of an injection, it's not such a problem in clinical practice. But this could be something that you need to explain to the patient, the two options. And regarding the other comorbidities, pioglitazone is not associated with, will not help to improve weight loss. On the contrary, we see patients gaining a little bit of weight with this therapy. So whereas we could expect a benefit in terms of weight loss as well with semaglutide, even if it's not at the dosage for obesity. The dosage for type 2 diabetes is lower, but still we can achieve weight loss thanks to the beneficial effect on satiety. So in my point of view, I think I would prefer in this clinical case and in usual in patients with NASH, the GLP-1 receptor agonist. With that said, just wanted to remind you also that we know that it's potentially will improve steatosis and NASH, but there's no benefit proven yet for the improvement of fibrosis regarding GLP-1 receptor agonist. We're waiting for data, and we will have data with the clinical trials that are currently on their way. And for pioglitazone as well, there's an effect in NASH. There's conflicting results in the literature regarding improvement in fibrosis, but it's not very strongly demonstrated. So this is also something we need to keep in mind. So really depending on the patient. And also one thing is that we do have some patient that start semaglutide and does not have side effects. And a few patients needs to stop because it's too important. So in that case, really you should switch to pioglitazone. So the two options are really possible for the patients.
There is another question regarding semaglutide. How long should be the treatment with semaglutide?
Yeah, excellent question. I think, yeah, this is a question we also have in the field of obesity now that we have treatment. I think we just need to remind us that it's metabolic diseases are usually chronic diseases, and usually we're giving the example that you wouldn't stop a treatment for dyslipidemia or hypertension. In case of a patient that is well controlled with semaglutide, usually it's for the long term. You're not going to stop the treatment, and I think it's probably be the case unless the patient lose a lot of weight and manage to control and change significantly the lifestyle. And this is also a case-to-case and patient individual decision. Should we stop? Maybe if the patient wants to stop, you can try to stop, but if the metabolic balance, glycemia and weight comes back, then just put it again on a semaglutide. I think this is the way we're probably going to manage the patient in terms of metabolic comorbidities.
Elisabetta, there is one question for you regarding the role of metformin for preventing the hepatocellular carcinoma. What is your opinion about that?
Well, this has been suggested by several retrospective studies conducted on people with type 2 diabetes, and in comparison particularly with insulin. So it looks like it is better metformin rather than insulin in this diabetic patient with liver disease, but there is no prospective study that can confirm that. So no one has done a prospective study seeing the longitudinal effect of metformin, not retrospective. And this is unclear also in non-diabetic subjects.
I have a question for Elisabetta and also Cyril. So you said both that cardiovascular disease is the main driver of death in NASH. So we all know that. We need to control the cardiovascular risk and especially arterial hypertension. I was wondering if there is a class of antihypertensive drug that could be preferred in NAFLD. I am thinking about, angiotensin receptor blockers that have been shown, mostly in preclinical studies, I agree, but have been shown to suggest to have antifibrotic properties in chronic liver disease. And we know also that telmisartan has some PPAR gamma activities. So with the knowledge we have today, are all the antihypertensive drugs equal in front of NAFLD? Or do we have some clues suggesting that some class could be preferred for the treatment of arterial hypertension in NASH patients?
Cyril, you want to go first and then I follow?
Okay, I can try to answer this very difficult question. Thank you, Jerome. I don't think we do have strong evidence of a better antihypertensive drug than another instead of liver. I would reverse the question. There is no also drugs that would harm the liver, which also is a good thing if you need to at least choose an antihypertensive drug, and it will have a benefit in terms of cardiovascular disease. But the renin-angiotensin system has been also shown to have other benefits, so in terms of kidney disease. So I would prefer this one in my patient, definitely, and these are the recommendations. So, but I will leave it to Elisabetta regarding preclinical data and potential clues of liver benefits of these therapies.
Well, actually, there are no so solid data to advise on the use of one hypertensive drug rather than another. So there are just suggestions. ACE inhibitors can be one class drug that is appropriate. I would just remind that cardiovascular risk in this patient is not just ischemic, but it's also related to diastolic dysfunction, which is a completely different etiology. Diastolic dysfunction is leading to heart failure with preserved ejection fraction, contrary to the ischemic disease that leads to heart failure with reduced ejection fraction. So those are two different fields of research that needs to be implemented, and probably some anti-diabetic drugs are also acting on the diastolic dysfunction, but we are looking to it.
Okay, thank you.
Elisabetta, regarding the risk of cancer in NASH patients with advanced fibrosis, what is your recommendation? Is there any screening? I know there is no guidelines about that, but what is in your practice? Do you screen for colonic cancer?
Absolutely.
Independent of age. I mean, because when we look to the cancer in NASH patients, NAFLD patients, they is earlier age. They are younger than the previous cancer. And so what is your recommendation? You screen the patient for cancer?
I do screen the patient, but according to current guidelines, current to national guidelines. I mean, there is no certain indication to anticipate the screening, but sometimes we might forget to advise on the screenings. This is something that should be better investigated. You ask about familial history of cancer, maybe also not just primary, but other relatives. You ask about risk factors and so on. And I do not have the data to advise on an earlier screening. But usually in my patients, sometimes I advise to do that a little bit earlier.
Okay. I have one question for Cyrielle. Cyrielle, you mentioned the therapeutic option of bariatric surgery in your patients. I thought it was for morbid obesity. So you mean the patients with a body mass index of 31 with comorbidity, of course. It is an indication out of the liver disease.
Well, the field is moving as well, and we are talking more and more about metabolic bariatric surgery. In the case I presented, it could be an option, but it's approved, for example, in France, very recently it's been approved, but it's for a patient with diabetes that is uncontrolled despite of multiple therapies, so not exactly the case of the patient. And you know, we are also investigated with Philippe Mathurin the benefit of metabolic surgery in patients with F3, F4 that could benefit from a bariatric surgery, even though the BMI is lower than 35. So this study is underway, and I hope it's going to help us, you know, decide if it's beneficial or not. But definitely we know that bariatric surgery may improve even liver fibrosis, and it could be an option in the future. But We are waiting for solid data. For diabetes, it's already approved in France.
Jerome, we have question?
Yes, Laurence, there is no more question. Unfortunately, we are at the end of the session. We need to leave. Many thanks to all the speakers and also for the people who are attending. This was very nice session. I hope you have enjoyed it and you also will enjoy the rest of the Congress. Many thanks to all. See you soon. Bye.
Thank you. Bye-bye.
Bye.
Bye.